Okay. Got it. Is it audible?
Yeah.
Yeah. Sorry for a short interruption. I hope the voice is loud and clear for all of you. Now, doctor, what are the primitive reflexes and Moro's reflex? Basically, our frontal lobe in the brain inhibits our primitive reflexes. Frontal lobe takes some time to mature. So that is the reason when we are born, there will be some of the primitive reflexes. Once frontal lobe matures, they are all gone. So what is Moro's reflex? Typically, it starts by 28 to 32 weeks of gestation. And it is complete by 32nd week of gestation. And it will disappear by 3rd to 6th month. So basically, you will take the baby, the head is dropped, that lead to sudden extension of the neck, which is called as Moro's reflex positivity. So there is a abduction, extension, adduction, then flexion of arms and fingers, right? So this reflex is called Moro. So favorite question of the examiner, when will Moro disappear? By 3rd to 6th month it will disappear. And any persistence of the Moro beyond 6 months indicates there is cerebral palsy. The most common cause, if the Moro is not present, also abnormal at birth. That means there could be a CNS depression if there is any anesthetic agent or any hypoxic ischemic encephalopathy in the preterm baby that can make Moro absent. Asymmetrical Moro, only one side gone into extension, means the other side is unable to abduct. That means there is an Erb's palsy which is very common while delivering the baby vaginally. Any clavicular fracture or spastic hemiplegia can cause asymmetrical Moro. Erb's palsy, where is the injury, doctor? C5, C6 nerve roots, right? I leave the literature for you. What are the other reflexes when they appear, when they disappear? You have to be 100% sure. Yeah, thank you. I hope the voice is loud and clear for all of you. Now, doctor. Palmar grasp. That means if you hold the finger, the baby will hold your finger. It appears by 28 weeks of gestation. And it will disappear by 3rd month. Right? So, I leave all the list, which you have to take a chance to run through. Now, what are the various motor, gross motor milestones? with both the hands, bidextrous reach, and control of the head holding comes by 4th month. The baby will roll over, sits without support by 5th month. Sits tripod, foot to mouth coordination is 6th month. And he crawls, pulls to stand, cruises by 9th month. So all this list we need to remember, doctor. Invariably, out of 10 questions, 1 question is developmental milestone. This is another favorite question. He pedals the tricycle by 3rd year. He transfers the objects. This is fine motor. The gross motor is fine motor. And this is another favorite question. He jumps on 1 foot, hopping, comes by 5th year. Sorry, jumping on 1 foot. Hopping on 1 foot comes by 4th year. Heel toe walk comes by 5th year. He climbs the stairs alone by 2nd year. Right? And he walks downstairs by 3rd year. Whereas upstairs by 2nd year. So getting up the ladder in our life comes early. To fall down will come little late. So similarly, fine motor activities. Tower of 6 to 7 cubes, tower of 9 cubes. When will he draw the cross, square, triangle, builds gate and bridge, 4th to 5th year? Anni koncham jira. Or he buttons the clothes, dresses under supervision. All that occur by 4 to 5 years. So, doctor, next. There are certain red flags. If they are there, we need to be careful. If the baby has no visual fixation, by 2nd month it is abnormal. He can visually track by 4th month when you show an object, red flag. Similarly, no response to sound or voice by 6th month, abnormal. No babbling of the consonant sounds by 9th month, abnormal. Not sitting without support by 9th to 10th month, abnormal. So please review all these red flags. Then comes the APGAR score. So fundamentally, what is the name of full form of APGAR? Appearance, pulse, grimace, activity, respiration. It is done 1 minute, 5 minutes after the birth. And APGAR 1 minute less than 7. Then you need to continue scoring every 5 minutes up to 20 minutes. APGAR maximum score is 10 points. And each parameter, if absent is 0, if present is 2. Appearance, pink, 2. Pulse more than 100, 2. Grimace, cries, coughs, sneezes, 2. Any active movement is 2. Respiration, good crying. Score is 2. So how to interpret the APGAR? You need to quickly review. Like in exam, they give the question like, a term baby at 1 minute of life has a pink body, heart rate of 110, grimaces to suction, flexion of the limb and irregular breathing. What is the APGAR score? So you need to calculate accordingly. Okay, doc?
Oh, I thought only 0 or 2. So after they were given.
Oh no, 0 to 2. 0, 1, 2.
Oh, 1.
मतलब దీనిలో గ్రేడ్స్ ఉన్నాయి 3 గ్రేడ్స్ एब्सेंट इज 0 प्रेजेंट इज 2 बीच में थोड़ा उतना ज्यादा प्रेजेंट नहीं है is 1. Right. So next, what is the head size at birth? Our head is 65 to 70% of the adult size by birth, and it becomes 90% by of adult size by 2 years. Similarly, there are certain bones which are being taken to assess the bone age. There is one thing called chronological age, which comes with our dating from date of birth. Other is the maturity of the bone. So bone age in the newborn, to assess that, what do you do? Foot and ankle. 3 to 9 months, we use shoulder. 9 to 12 years, X-ray of the hands and wrists. 12 to 14 years, elbow and hip. So you need to remember which bone at what age. So a 6-month-old should be done bone age assessment using what? So shoulder. So purely mugging wala items hai. But don't be scared, because first time they are anonymity, second time they are relevance, third time it is authority. So one has to pass through those stages inevitably. The weight doubles by 5th month. न्यूबॉर्न बेबीज वेट 3 किलो का बच्चा 5वां महीना में 6 किलो बन जाएगा. It triples at 12 months, quadruples at 24 months of age. So it becomes 5 times by 3 years. That is, 3-year-old kid is supposed to be 15 kgs. Between 3 years to 7 years, there is a weight gain of 2 kilos per year. So he can ask, a 5-year-old kid weighs how much? So by 3rd year, he will be 15 kilo. 2 kilos in 6th year, 2 kilos in 7th year.
Yeah.
So 4 plus 15, 19 kilos. Atla. The height at birth is 50 centimeters. 0 to 6 months, there is a 2.5 centimeter height per month. And 6 to 12 months, it is 1.25 centimeter per month. From the birth weight of 50 centimeters, by 1 year, when he celebrates the birthday, he is a 75 centimeter scale. Increased by 50%, 25 centimeters badega. The height doubles by 4 years, height triples by 13 years. That means he will reach 5 feet. 50 centimeter ka tripling is 150, which is almost 5 feet by 13th year. And the height growth after 4th year is 6 centimeter per year till puberty. Equally koltalu calculations like a tailor, we should remember. Head circumference at birth, 35 centimeters. Then when do you call microcephaly? Whenever it is more than 3 standard deviations below the mean, you call microcephaly. More than 2 standard deviations above the mean, you call macro. Now, what are the causes of microcephaly? Torch, toxoplasmosis, rubella, cytomegalovirus, herpes simplex, congenital infections. Similarly, varicella means chickenpox, cytomegalovirus. They are the congenital infections that can lead to microcephaly. Trisomy 18, trisomy 13, credichat, which is 5th chromosome short-arm deletion. Credichat. They all have microcephaly. Similarly, Angelman syndrome, fetal alcohol. If the mother takes alcohol during pregnancy, fetal alcohol, microcephaly. Phenylketonuria is microcephaly. Now, doctor, what is the chest circumference at birth? It is 3 centimeters less than the head circumference is chest circumference at birth. Chest circumference equals the head circumference by 1 year. And chest circumference is more than head circumference after 1 year. So that is what you need to remember. When do you call delayed dentition? By 13th month also teeth don't appear, you call delayed dentition. So what are the causes? Familial. Few people teeth आता जरा उनके दादा परदादों में भी वही रिवाज है कि teeth will come late. Then rickets can cause. You need to evaluate any vitamin D deficiency. Endocrine disorders like hypothyroidism can lead to delayed dentition. Right? Now, what is the definition of a short stature? If the height is less than 3rd percentile or less than 2 standard deviations below the expected height for a given age, you call short stature. If the height is less than -3 standard deviations, you call pathological dwarfism. And pathological short stature, typically less than 3 standard deviations. What is the most common cause of short stature? Constitutional growth delay. Matlab, I used to be the shortest kid in the 9th class. Just 4 feet. I used to not have confidence to say hello to any of the girls in the class. All used to be tall. 10th class worst situation. All girls became madams. But I'm still a kid. I don't know. In the 10th class summer, suddenly I grew to 5 feet 9 inches. So they're called late bloomers. Constitutional delay of growth. Just like in mock test, suddenly 46 to 52 is a leap.
Yeah.
So think that, okay, there is a little late blooming. But once bloomed, they go to 6 feet. Right? Another thing is our spirits will also improve. When we score high.
Yeah.
I know almost 3 lakh students took coaching virtually. Out of them, at least personally, I might have sat like this with around 10,000 doctors in the last 25 years. There are people, when they start their preparation, or even 1 month before preparation also, they are 40% scorers. But that 1 month they will make up to 70%. क्या हो जाता ना, by in this last 20 days our physiology will spike up, and we are naturally cricketers, sports people, no. So that's the reason. What is cricket ultimately? 2020 match only, no. So now we are last 5 overs, we are having a goal to finish around 80 to 90 runs.
Yeah.
Let's do that. The whole fun of cricket is that, right? Then familial short stature means everybody in the family is short, he is short. That is different from constitutional delay of growth. Just there the growth reaches the ultimate adult size, but little late. Then once more, whenever short stature is there, you look at proportionate and disproportionate. That means if upper segment is shortened, lower segment is also shortened, you call proportionate. But only upper segment is normal, but lower segment only below the belt area, lower segment is short, disproportionate. Now, doctor, I leave the literature for you. Other points to quickly go through. So disproportionate short stature, most common cause is achondroplasia. Short limbs is a feature of achondroplasia. Short trunk is a feature of mucopolysaccharidosis. You remember Hunter's disease, Hurler's disease? Avanni mucopolysaccharidosis, trunk short. Then constitutional growth delay. Most common in boys. Short height, they have a delayed bone age and delayed puberty. Whereas if you take familial short stature, it is common both in male and females because their family has a history of shortness. They are short, but they have a normal bone age, normal puberty. That's the difference. What is the difference between constitutional growth delay, late bloomers and familial short stature, delayed puberty is constitutional. Now, bone age less than chronological age. A 15-year-old, when you check the maturity of the ossification centers, there is a particular age at which ossification centers are supposed to mature, fuse. If there is an immaturity, right? So, bone age less than chronological age. उनका डेट ऑफ बर्थ के तरफ देखे तो 16 साल का है, मगर उनका एपिफाइजियल फ्यूजन टेस्ट करे तो he looks like 11-year-old kid. That's called bone age less than chronological age. Constitutional growth delay and growth hormone deficiency associated dwarfism also. Bone age less than chronological age. How will be the final height in constitutional delay? It is usually normal. Then what is the final height in familial short stature? It is short because shortness is a part of their family. Now, if you look at the growth hormone deficiencies, dwarfism, 2-3 points to be remembered. Upper segment to lower segment is normal. It is a proportionate dwarfism, not disproportionate. Disproportionate is only achondroplasia. Then bone is delayed more than 2 years. And there is a normal birth time may weight by height. Okay? Now what is the sequence of puberty in girls? Thelarch comes first, that is appearance of the breast bud. Pubarch, development of pubic hair. Then adrenarch, peak, that means axillary hair and all. And peak growth, then menarche. Boys may testis enlarge first, then pubarch, adrenarch, growth, then beard. So, somehow you need to remember. Where do you get delayed puberty with normal bone age? In the familial short stature? Puberty normal.
Both is delayed.
Bone age is delayed, no?
Both even puberty.
Is it correct? No?
Late. Fine, brown delay.
ఇది ఒకసారి రీచెక్ చేయండి. నార్మల్ బోన్ ఏజ్ అయితే అనుకున్నాం, కానీ ప్యూబర్టీ కూడా నార్మల్ అనుకున్నాం కదా ఫెమిలియల్ షార్ట్ స్టేచర్లో. జస్ట్ రీచెక్ దట్. సో షార్ట్ డిలేడ్ బోన్ ఏజ్, డిలేడ్ ప్యూబర్టీ, నార్మల్ ఫైనల్ హైట్ ఈస్ కాన్స్టిట్యూషనల్ డిలే. Normal bone age, normal puberty, target height is achieved, short is familial short stature. I think this statement needs to be corrected. Okay? Because this is normal puberty in familial short stature. So, first visible sign in case of the boys is testicular enlargement by 9th to 10th year. First visible sign is thelarch. Now, which is that hormone called permissive hormone in puberty. So basically in girls, your gonadotropin releasing hormone is capable of releasing. Your FSH-LH is capable of producing from pituitary. Your ovary is ready to produce estrogen right at birth. But it is the leptin which will decide that when the girl matures, enters puberty, That time it will let all these hormones to get released. So hence leptin is called permissive hormone of puberty. So what is the main trigger of puberty? Suddenly pulsatile release of the LHRH, FSH releasing hormone from hypothalamus will start. Okay? Now, doctor, how do you know fetal anemia? Middle cerebral arteries peak systolic velocity is a very reliable test. So you will compare that with the umbilical arteries. The pulsatility index, based on which you will identify fetal anemia. Then whenever there is a RH isoimmunization, that is RH negative mother with RH positive baby, you need to give anti-RHD prophylaxis. So how much you will inject? 1500 international units, which is 300 micrograms, IV or IM at 28th to 30th week of gestation. It is given 28th week once more within 72 hours of postpartum. Because at the time of labor also there can be feto-maternal transfusion and the baby's positive, RH positive cells can enter the maternal system, which is RH negative, and invoke the antibody memory in her body. So that next baby, when she becomes pregnant, it get attacked. We don't want that. So when will you give Rogam antibody? Postpartum within 72 hours of delivery if the baby is RH positive. Then until when, suppose if in a villager, it's not done, up to what age you can still give that so that you can prevent allosensitization? Up to 4 weeks if it is missed. What type of events lead to feto-maternal transfusion other than the labor, which also require to be given RH antibody? If a RH negative woman had a ectopic pregnancy, abortion, amniocentesis, any trauma, chorionic villus sampling, or you have done external cephalic version, in all these scenarios you need to give Rogam. Rogam means RH immunoglobulin, which is a passive way to prevent it will go and block.
Even if the baby is like rhesus negative or positive, you have to give.
RH positive baby with RH negative mother unte, will give labor. అట్లా కాకుండా డెడ్ బేబీ ఎక్టోపిక్ ప్రెగ్నెన్సీ amniocentesis, we don't know the status. కాబట్టి వీళ్ళందరికీ ఇచ్చి పడేయాలి. Good to see 5 online classmates every day, at least 6 to 9. I try to revise one subject, and by 25th, 4th, we finish all 19 subjects. You will get the PDF of all this quick, sure, short, high yield facts revision notes. So please join the live session every day.
Coffee on this.
Now, how do you detect the fetal blood? Whether it gone and mixed with the mother's blood, how do we know? Feto-maternal bleeding. We do clean Hoyer-Betke's test to estimate the feto-maternal bleed. Right? And based on that, you will decide how much dose need to be given. Aim test adi clean Hoyer-Betke. Inkote apt test. What is apt test? Basa previa means it has got fetal blood. Placenta previa is only maternal blood. So whenever there is any antepartum hemorrhage, you want to know which bleed. For that we do the APT test. It is also called alkali denaturation test because we use the alkali NaOH. Okay. Now, whenever there is a RH isoimmunization and newborn baby has hemolysis, then you need to do exchange transfusion if his jaundice is severe. Then once more, peak systolic velocity of the middle cerebral artery suggests fetus has anemia. Suppose if there is any isoimmunization, it happens within the womb for the second baby. Maternal antibodies will start hitting.
Yeah.
So how do you detect whether that second baby is having the effect of the maternal antibodies? You do the, then if the antibodies go, that lead to hemolysis in the fetus, leading to fetal anemia. So that need to be detected by doing the middle cerebral artery peak systolic value. Velocity is more than 1.5 units. It suggests fetal anemia. One factor. Try to remember. What is the page number?
48
Out of?
261.
Okay. 20% download over.
Yeah.
40 minutes, huh?
Yeah, 40.
Can the online students can punch? Is the voice loud and clear for all of you, doctor? I hope the voice is loud and clear. Now, so RH isoimmunization is called immune hydrops. There are certain causes which are called non-immune hydrops. Hydrops fetalis, when the baby develops fetal anemia, he will go into congestive heart failure with all NSRK and all that. That's called Hydrops fetalis. Immune cause for that is RH immunization. Non-immune causes you should know. Down syndrome, Turner syndrome, similarly, any supraventricular tachycardia, heart block, and torch group of infections, parvovirus B19. Similarly, other than RH isoimmunization, if there is any thalassemia major, G6PD deficiency, they all can lead to Hydrops fetalis. Please go through this. Similarly, any maternal diabetes, maternal anemia, thyrotoxicosis, hypoalbuminemia, meconium peritonitis, anything can lead to the development of non-immune Hydrops fetalis. Basically, Hydrops fetalis is the congestive heart failure in the fetus, leading to NSRK because of the underlying fetal anemia or fetal heart disease. Now comes three conditions, doctor. Neonatal pneumonia, transient tachypnea of newborn, and respiratory distress syndrome. Anything, everything about it you should know, right? What are the three conditions?
Neonatal distress, transient tachypnea. Third one.
Respiratory distress syndrome. So transient tachypnea of newborn. It's very benign, self-limited, typically seen in term infants. Whereas respiratory distress syndrome is seen preterm. So whenever you do cesarean section without labor, the lung of the baby, there will be a collection of the fluid in interlobar places. Or if there is a precipitous delivery in a grand multipara, suddenly baby is born without any, bole to aa jate bahar. Bahar transient tachypnea can occur. Two risk factors. It is the delayed clearance of the fetal lung fluid that lead to the development of the transient tachypnea. Generally, it will resolve within 72 hours after the delivery. So this is how typically transient tachypnea of the newborn radiograph looks like, where in the interlobar fissures there is a fluid collection in a cesarean delivered baby. So that is the reason tomorrow in entrance exam he will give like this. Is it pneumonia, TTN, or meconium aspiration or respiratory distress? The clue addindi. Where is the clue? Born by elective, correct, term baby, cesarean history, resolved by 48 hours. Right? Now, so what do you see? Interlobar fissures, there is a fluid collection, hence they are prominent. And there is a hyper-inflated lungs. That's how you see this. You give oxygen, in less than 72 hours, it will resolve. And the respiratory distress is only minimal or sometimes no distress. Then, bronchopulmonary dysplasia. It's a chronic lung disease typically seen in preterm infants who are treated with oxygen and ventilation, because oxygen free radicals will go and damage the pulmonary system, leading to dysplastic changes in the bronchi, which is called bronchopulmonary dysplasia in the preterm neonates. So the barotrauma, oxygen toxicity, surfactant deficiency, fibrosis, they're all responsible. So there's a respiratory distress, tachypnea, tachycardia, which will worsen with effort. So how do you treat it? You administer surfactant into their lung, oxygen, and do CPAP, continuous positive airway pressure, and mechanical ventilation. Ventilator bhi lagana padta. Next comes meconium aspiration. It occurs in post-term baby, not preterm. So whenever post-term baby, even it can occur in term. So at the time of delivery, if there is any difficulty, that hypoxia relaxes the anal sphincter and all the meconium, which is the fecal matter, get released and enter amniotic fluid, which is aspirated by the baby. Go to the sequence. During the vaginal delivery, if there is any obstructed labor, the baby will suffer fetal the newborn will suffer hypoxia. That relaxes the anal sphincter, releases the meconium, enters into the amniotic fluid. At the time of delivery, he will aspirate that, leading to meconium aspiration. It's more common in term, post-term, small for gestational age and large for gestational age infants. Small for gestational age and in the preterm and they are different.
Yeah.
For every gestation, you expect certain weight.
Yeah.
Even a term baby is expected certain weight.
SGA is same as microsomia.
Microsomia. Microsomia and fetal head diameter is narrowed.
Okay.
That is microsomia.
Right.
SGA means, sorry, that is microcephaly. You said microsomia. No?
Yeah.
Macrosomic is large for, correct.
Okay.
You are right. Now, and instead of 3 kg, he is only 1.5 kg in spite of term.
Yeah.
That becomes short for gestation.
Yeah.
Similarly, a diabetic mother is there.
Yeah.
She produced a 5 kg baby.
Yeah.
At term.
Yeah.
Term baby is not expected to be 5 kg. Then it becomes a large for gestational age is what you need to remember. Thank you, Dr. Patil, for the feedback. Hope the voice is loud and clear for all of you. Okay. Any pay 50, yeah? 52. Okay. Almost 25% we are. గంటకి 30% అయిపోతుంది. 3 గంటలు అయిపోతుంది. షోలే మూవీ 3 घंटे का మూవీ. ఇవన్నీ ఏంటంటే one should generate some amount of interest by reading this. Then a filter coffee in the filter in the
sugar.
Parle. Thank you. Sugar. Thank you. So from 25th, I'll be missing this coffee session. So what is the psychological incentive for us to bite line to line? Remember, because every subject, if you finish revision, without revision, without reading, you will get 2 out of 10 marks. With reading and revision, the chance is that you will score 6 out of 10 or 7 out of 10. So that is increasing almost out of the total score of 300, 5-6 marks addition will make your score shoot up by 5 marks of 300. 6 marks of 300 is about per subject.
20%.
5 out of 300 is about 2%. Your score will improve. Every day 2% score improves. From 52%, you will reach 70% by D-Day. Atla. And కొన్ని forgettable things, try if you get time. At least this will give you that elimination skill to correctly reach to the answer. మళ్ళా మాక్ టెస్ట్ లో మిస్టేక్స్ కూడా జర చూడండి. Now, what leads to meconium aspiration? That meconium will lead to obstruction, and that obstructed bronchi not ventilating will undergo that part of the lung. Suppose if bronchi in the, if that got obstructed, that lung it supplies, that lobe will go into atelectasis, collapse. Then meconium itself is a chemical, and that lead to chemical pneumonitis. They're all the pathogenic factors. So what do you see in meconium aspiration? There'll be areas of collapse, there'll be areas of leakage of air, and heterogeneous opacities and hyperinflated lung. That is how meconium aspiration typically presents. So pneumothorax, pneumomediastinum, and pulmonary hypertension, whenever meconium caused impaired oxygen transfer, that hypoxia lead to pulmonary vasoconstriction leading to pulmonary hypertension. And the prognosis, usually it will improve within 72 hours. Meconium aspiration. So any respiratory distress in a newborn baby within 1 hour of life, deteriorating over 24 to 48 hours, you should think of meconium aspiration. So can you be able to do tracheal suction and take out that meconium? If the baby neonate is vigorous, don't do that. That is a guideline. How can you prevent meconium aspiration? If you try to do the deep suction, newborn puttangani, they will do suction. Because his face is coming out of the pool of fluid, right? Whether cesarean or vaginal. Don't do deep suction or don't try to put the finger in the mouth. That will lead to more aspiration. Then the treatment is oxygenation, ventilation, surfactant if needed. So main difference between transient tachypnea, distress is minimal in transient tachypnea but severe and progressive in meconium aspiration. Okay, now? This story. Now comes respiratory distress syndrome. It is also called hyaline membrane disease. Typically seen in preterms less than 34 weeks and incidence less than 28 weeks of birth will be 80%. So 26th, 27th ke pudtar kada babies valalo respiratory distress is very high. The most important risk factor is prematurity, preterm, and any birth asphyxia, diabetes in the mother. Caesarean section increases the risk of respiratory distress and multiple gestation. That is twins. Then what are protective factors? Paradoxically, if there is a preeclampsia in the mother, that protects against the respiratory distress. Now, why diabetes of the mother lead to respiratory distress? Respiratory distress syndrome is a state of surfactant deficiency. So maternal diabetes में क्या होता? Maternal hyperglycemia. All that glucose enter into the baby. That lead to fetal hyperglycemia. That lead to fetal hyperinsulinemia. Insulin is inhibitor of surfactant production. That's the reason diabetic mother will lead to fetal respiratory distress syndrome and surfactant deficiency. Clear? So collapsed alveoli, hyaline membranes are the pathological hallmark. So tachypnea, retractions, grunting, cyanosis within 6 hours after the birth is suggestive. They'll have retraction, intercostal spaces will be retracting. Tachypnea will be there. So there'll be a ground glass, reticulogranular air bronchogram, means you can see the air spaces because of that interstitial edema. Whiteout lungs, they are the features of respiratory distress syndrome. So the whiteout lungs, you can see the bronchi, air spaces in case of respiratory distress syndrome. And the LS ratio is more than 2 suggests mature lung. Lecithin sphingomyelin ratio. గుర్తుందా? మొన్న అడిగాను కదా నేను క్వశ్చన్, ఎల్ఎస్ రేషియో నార్మల్ ఎంత అని ఆబ్స్టెటిక్స్ లో. మరి అది గుర్తుంది, ఇది మరి. Similarly, surfactant to albumin ratio, SA ratio, less than 35 is immature, more than 55 is mature lung. So what is your target PaO2 in a baby who is having hyaline membrane disease? PaO2 should be brought to 50 to 70, SpO2 to 91 to 95. If SpO2 is less than 90%, when you are doing CPAP, then that is an indication to give surfactant and you need to intubate. CPAP is a non-invasive way of, non-invasive, मतलब trachea में कुछ भी नहीं चलाते. You don't put an endotracheal tube and connect to ventilator. That is invasive. CPAP is with positive pressure through the mask, you will be blowing the air. So the moment SpO2 continues to be less than 90% on CPAP, then you need to give surfactant, do intubation and mechanical ventilation. How do you give surfactant? Not intravenous, endotracheal tube.
BiPAP is invasive.
BiPAP is ade continuous
Non-invasive.
positive, non-invasive.
Oh,
Any PAP is
oh, no. Okay.
PAP is non-invasive, right?
Yeah.
You are just blowing positive airway. BiPAP is ventilator mode. Adi.
Ade bi.
BiPAP is a ventilator mode.
Yeah.
CPAP is continuous positive airway pressure. Those who have obstructive lung disease with a lot of obesity, no,
Yeah.
there will be a machine, CPAP machine.
Yeah.
So they put it and sleep in the night.
Yeah.
Adi. Now, how can you prevent? So what is ECMO? Extracorporeal membrane oxygenation. There is one ECMO unit. Basically, extracorporeal. Corpus means body, outside body, membrane oxygenation. So now, how do you prevent? Antenatally give steroid. Give betamethasone 12 milligram IM fourth hourly into IM into 2 doses. Or dexamethasone 6 milligram 12 hourly 4 doses. So any mother less than 35 weeks going into the delivery is at risk of respiratory distress in the newborn.
Yeah.
Steroid is given. So what is the rule of 24? This 12 milligram is given 2 doses is equal to 24, or 6 milligram dexamethasone is given 4 doses. Then what is the timing of RDS symptoms? Typically within 6 hours of birth is what you need to remember. Right, doc?
Yes.
So enta indi total download 60.
Yeah.
Time? 1 hour. Okay. We'll take a short break. Now, continuing our journey, doctor, beta-methasone is one option, dexamethasone is the other. Generally, beta-methasone is the one which is preferred. So, beta-methasone 12 milligram IM, 2 doses, 24 hours apart, or dexamethasone 6 milligram IM, 4 doses. Right? Now, the next important area is neonatal sepsis. Early onset neonatal sepsis, when do you call? Whenever it occurs within 72 hours. And the most common organism is group B streptococci, E. coli, Klebsiella. These are the within 72 hours. After 72 hours, whenever the neonatal sepsis occur, it is the staphylococcus and gram-negative bacteria. You are comfortable there?
Yeah.
I am quite behind.
Yeah.
Yeah. Then, what are the cause of early onset neonatal septicemias? Hope the voice is loud and clear. Can the online students give a feedback? So whenever the baby is getting delivered, there is a maternal flora which is responsible for early onset. Whereas Sister Lily, whose hands are very silly, can lead to late onset neonatal septicemia. Pneumonia, multi-system involvement is feature of early onset. Meningitis is the feature of late onset. Most common bacterial agent of all is group B streptococcus in early onset and staphylococcus in late onset. So please don't forget, doctor, these are all very fundamental questions, right? You need to review all this. Then comes, in a preterm baby, one of the complications is hypoxic ischemic encephalopathy. So typically, whenever there is any obstructed labor or a preterm baby, there is a systemic hypoxia, reduced cerebral blood flow that lead to ischemic damage to the brain, which is called hypoxic ischemic encephalopathy. So what is the criteria? When there is an acidosis with a pH less than 7, APGAR 0 to 3 at more than 5 minutes, and multi-system damage, you call hypoxic ischemic encephalopathy. It leads to seizures, coma, and encephalopathy. Favorite question. What is the gold standard if you are suspecting hypoxic ischemic encephalopathy to make a diagnosis? Diffusion weighted MRI is the gold standard where you can see the hypoxic ischemic encephalopathy. You'll remember, right? So they can ask the questions like, there is a sepsis. What are the sepsis screen parameters which will be positive? So TLC will be low, platelets are low, CRP is high. 3 positive parameters. Similarly, a term neonate with perinatal hypoxia, multi-organ dysfunction, APGAR 2 to 5, what is your diagnosis? Hypoxic ischemic encephalopathy. Right? Now, doctor, let's talk about the neonatal hypoglycemia. Whenever the blood glucose is less than 40 in a neonate or post-neonate, if it is less than 45, that defines the neonatal hypoglycemia. When do you call hyper? When the blood glucose is more than 125, you call hyperglycemia. So, whenever there is an asymptomatic hypoglycemia, there can be. Sometimes when the blood glucose is 20 to 40, still the baby may not show the signs of hypoglycemia. You need to start the breastfeeding. If there is a symptomatic hypoglycemia, where blood glucose is less than 20 and baby is showing jitteriness or seizures or any of the features of hypoglycemia, then you need to give 10% dextrose, 2 ml per kg. IV bolus is considered to be the management. So what are the hallmarks of hypoxic ischemic encephalopathy? Right? So there is a subcortical necrosis, periventricular hemorrhage, periventricular leukomalacia, which is the white matter of the brain will show the malasic changes. Periventricularly, white matter, leukomalacia is the hallmark of hypoxic ischemic encephalopathy. Then there can be a parasagittal infarct, basal ganglia infarct. They can all be the features in term babies. At least definition of hypoxic ischemic encephalopathy gurtupettukunte super. Now comes, what are all the various congenital heart diseases that you see in case of the diabetes in the mother? If the mother is having maternal diabetes, the baby will have most commonly VSD. But of all cardiac abnormalities, what is most specific to say that it is due to maternal diabetes? Transposition of the great arteries, where aorta, instead of opening into the left ventricle, it opens into right ventricle, and pulmonary artery, instead of opening into the right ventricle, opens into left ventricle, is most specific. ఈ రెండు గుర్తుపెట్టుకోవాలి గురుగారు. Most specific ఏది, most common ఏది. So whenever maternal diabetes is there, what is the lung complication? The baby will have respiratory distress syndrome because of the inhibition of surfactant. Then maternal diabetes leads to maternal hyperglycemia, which translates into fetal hyperglycemia that stimulates fetal hyperinsulinemia. You know, insulin is anabolic hormone. Because of that, what will happen? The baby will grow to 5 kgs instead of 3 kgs. So macrosomia is the consequence of fetal hyperinsulinemia as a consequence of the maternal diabetes. Similarly, the newborn born to the mother who is diabetic will have hypoglycemia, polycythemia, hypocalcemia. Ivi characteristic combination. And because of that hypocalcemia, he can develop seizures. Hypoglycemia, he can develop seizures. What is the abnormality in the kidney that you see if there is a maternal diabetes? Renal vein thrombosis. Most specific defect for maternal diabetes leading to baby effects in the baby is caudal regression syndrome. Okay? ఇది మళ్ళీ దాని మీద పెట్టాల్సి వస్తుంది. ఇది కొంచెం నాకు పొజిషనల్ వర్టాయిగా వస్తుంది.
Table.
I'll sit and teach.
Okay.
So this is a favorite question of the examiner. Macrosomia, hypoglycemia, polycythemia, hypocalcemia leading to seizures is the feature of the baby born to the diabetic mother. Similarly, renal vein thrombosis, caudal regression syndrome is caudal and sacrum regression. And you can also go through the image. Similarly, duodenal atresia is a GIT abnormality seen with the maternal diabetes. Similarly, hepatomegaly because of glycogen storage. And large baby while coming out will have a shoulder obstructed, shoulder dystocia, birth trauma. They're all the features. Now, in the cardiovascular system, there is a hypertrophic cardiomyopathy, that is interventricular septum become hypertrophied. And respiratory distress syndrome is a risk factor always with maternal diabetes. Yeah. Then in the GIT, duodenal atresia is one thing. One more thing is small left colon syndrome. Left part of the colon means sigmoid colon and all. They become small. So that is the story. All right, doctor. Next we come to a very, very, very important area, jaundice. Any neonatal jaundice occurring in less than 24 hours after the birth is considered to be pathological. And the most common cause of the pathological jaundice is RH isoimmunization, where RH positive baby with RH negative mother in the second delivery will lead to jaundice. Similarly, ABO incompatibility. The baby's ABO, so for example, B positive. B, mother is A. That also can lead to pathological jaundice. Similarly, torch group of infections can cause jaundice. G6PD deficiency, pyruvate kinase deficiency, glutathione synthetase can cause. Thalassemia, spherocytosis can cause. Excessive vitamin K. There is an entity called hemorrhagic disease of newborn. To avoid that, what we do, we give vitamin K injection. If that is too much of dosage, that also can lead to development of the jaundice. Similarly, galactosemia, Crigler-Najjar syndrome, hypothyroidism, anything can lead to neonatal jaundice. Any jaundice developing after 24 hours up to 72 hours is considered to be physiological. At the time of the birth, if there is any cephalohematoma, the blood inside that cephalohematoma also can lead to the development of the jaundice. There's an entity called breast milk jaundice, breastfeeding jaundice. Breast milk jaundice occurred more than 72 hours. It is benign. It peaks by the time the baby reaches 2 weeks. Breastfeeding, it is due to the first time mother doesn't know how to feed. Between the nipple and the mouth of the baby, the latching is not happening. So poor feeding or dehydration can lead to breastfeeding jaundice. Breast milk jaundice antenemo, there is one substance in the breast milk that lead to the development of the impaired conjugation of the bilirubin, leading to unconjugated hyperbilirubinemia. Ademo breast milk. Idemo breastfeeding. If the cause is poor feeding, feed more breast milk for breastfeeding jaundice. If it is breast milk jaundice, stop breast milk. Adi difference. Good what is it? Idendi less than 7 days, that is more than 72 hours and peaks by second week. When do you call late jaundice? If it is a jaundice starting after 2 weeks, you call late jaundice, and commonly 3 causes. Metabolic disorders, infections, and biliary atresia are responsible. Very high yielding table. Every point in this is a frequently asked MCQ in the NEETPG exam, doctor.
Yeah.
So Sudhakar is asking, how can we get the PDF? 90008688356 call for PDF. Clear, doctor? Now, 1 gram of hemoglobin equal to 35 milligrams of bilirubin. Remember, in hemolysis, what is the time?
8:50.
Okay. And jaundice is called pathological if there is, conjugated hyperbilirubinemia. When do you call pathological? Out of the total bilirubin, if more than 30% is conjugated bilirubin, then that is abnormal. Now, what is the relation between where you see the yellowing of the skin versus the level of the jaundice? If the total serum bilirubin is more than 5, then you will start seeing the visible jaundice, right? And adults may, more than 2 milligram per deciliter will cause you to start showing the signs of jaundice. Kramer said, Kramer-Jones, when the bilirubin goes 4 to 6, the yellowing is limited to head and neck. 6 to 8, chest and umbilicus. 8 to 12, trunks and thighs. 12 to 14, arms and legs, and more than 15, palms and soles. Then what are the causes of unconjugated hyperbilirubinemia? Conjugated or unconjugated? Conjugated repository, if the bile obstructive, when the bile duct is obstructed somewhere, either due to biliary atresia, etc. Unconjugated hyperbilirubinemia occur with hemolysis, and physiological jaundice is unconjugated. There is an entity called Gilbert syndrome. In that, basically, the bilirubin need to be uptaken by the hepatocytes for it to be conjugated. Uptake defect is there with Gilbert. And Crigler-Najjar syndrome, glucuronyl transferase enzyme will be there, and that will be deficient in Crigler-Najjar. That also lead to unconjugated hyperbilirubinemia. Similarly, any sepsis, hepatitis also can lead to unconjugated. Now, why do you get breast milk jaundice? Dogs also feel envious. Yeah. How come I am missing the boardroom meeting? Yeah. Unacceptable. How can my boss can be close to somebody? Wait. The boss is preparing for exam. You have to wait. Now it is my time. How old is this?
2.5 years.
They live for 10 years.
10 to 20 depends on
no?
good health.
Oh.
వాళ్ళిద్దరు 14, 13 years.
Every-
Other two.
అవునా?
Yeah.
So, since your childhood, you have seen already one cycle of.
Yeah. Always had dogs inside.
Very sad to lose them, right?
Yeah, too sad.
So, doctor, good. Good to see 7 online classmates. Now, Dubin-Johnson rotor, where is the problem? The problem in rotor and Dubin-Johnson is conjugation happen, but that conjugated bilirubin need to be secreted out of the cell. That is the problem in Dubin-Johnson and rotor. Crigler-Najjar glucuronide transferase is deficient, so unconjugated hyperbilirubinemia. And Gilbert-lo uptake is defective for it to be conjugated. That's the reason Gilbert unconjugated, Crigler-Najjar unconjugated, Dubin-Johnson rotary secrete already conjugation हो गया, secrete करने में दिक्कत हो रहा है. Any cholestasis like hepatitis, cirrhosis, drug injury can lead to conjugated hyperbilirubinemia. Any biliary atresia, choledocholecystis, or any tumor can lead to conjugated. And any conjugated hyperbilirubinemia is always pathological, right? So what are all the pathological conditions? Any conjugated is pathological. Less than 24 hours is pathological. Beyond 72 hours is pathological. Only 24 to 72 hours is physiological is what we need to remember, doctor. And what is that substance in the breast milk which can impair the conjugation? Beta glucuronidase in milk, right, will lead to the impaired conjugation, leading to unconjugated hyperbilirubinemia. Right? Then, doctor, let's talk about Gilbert. What is the inheritance? Autosomal dominant. Actually, a lot of people will present with Gilbert in community. If they do starvation or दावत को जाके ज़्यादा खाया, नहीं तो fever आया, or they have gone for a police constable recruitment and they were doing exercise, then blood sample, if it is drawn, that will show unconjugated hyperbilirubinemia. But how will you identify it is Gilbert? It is called isolated hyperbilirubinemia. Isolated ka matlab SGOT, SGPT, alkaline phosphatase, all the enzymes are normal. Only bilirubin is elevated. That too, it is unconjugated. Then you need to suspect Gilbert. They'll have the history of sepsis or fever or exercise or starvation. Something will be there in the history. That's how Gilbert is identified. Nothing need to be done. You need to reassure the patient and it will resolve. Crigler-Najjar syndrome is autosomal recessive. Rotor and Dubin-Johnson are also. ఇందులో ఏది కాంజుగేట్ ఏది అన్కాంజుగేట్ చెప్పండి.
Gilbert and Crigler-Najjar are unconjugated. Rotor
Conjugated. The most common inherited hyperbilirubinemia is because of the Gilbert. Now coming to Crigler-Najjar. In that you have type 1 and 2. One maneto completely absent glucuronide transferase called UGT1A1 enzyme. I mean gene. Whereas Crigler-Najjar type 2 low, glucuronide transferase is not there, but it is only decreased, not zero. Completely absent nahi hai wo. वो थोड़ा benign है. Type 2 benign है, type 1 fatal. And if you give phenobarbital, it will increase the activity of UGT1A1. It is useful in Crigler-Najjar type 2. थोड़ा है तो improve कर सकते, कुछ भी नहीं है तो क्या कर सकते? हाँ. Then Dubin-Johnson. Dubin-Johnson is a secretory defect. The conjugated bilirubin is formed, but it is unable to get secreted. That's the reason it gets pent up inside the hepatocytes, and that gives a black appearance to the liver. And that is called piggy liver. It looks like the pig. Then rotor. Rotor syndrome is also very benign, secretory defect. Huh? Now, what is the difference between Dubin-Johnson and Rotor? Both of them are conjugated. But gallbladder is visualized on scan in Rotor, but not visualized in Dubin-Johnson. That's the difference between the two. Okay? Now, in Gilbert and Krieg-Lenazer, it is unconjugated. Rotor and Dubin-Johnson, it is conjugated. UGT1A1 gene, typically a defect in Gilbert and Krieg-Lenazer. Whereas OATP is the gene which lead to secretion of the bilirubin, is defective in case of the rotors. Gilbert, Krieg-Lenazer, rotor, in all this, type 2, in all this, histology is normal. But Dubin-Johnson, the black, coarsely granular pigment get deposited in the hepatocytes in Dubin-Johnson. Gilbert, Dubin-Johnson, it is benign, no treatment needed. Krieg-Lenazer type 1, you give phenobarbital, phototherapy, liver transplant. Phenobarbital is not effective, by the way. Type 2 phenobarbital, it is responsive. Right? So, idantha koncham gurtupeట్టుకోవాలి doctor. Now comes, kitna hai page number?
79.
Out of?
260.
260. Oh. Okay. Too many facts are tucked in a table. Some tables are like that. In kernicterus, where will the bilirubin go and deposit? In the basal ganglia of the brain. Basal ganglia are involved in our movement. That's the reason there is a chorioathetosis, cerebral palsy, all this can occur. And the upward gauge, horizontal gauge is controlled at pons, upward gauge is at the midbrain. That's the reason the upward gauge become limited in case of the kernicterus. So what are the risk factors for development of kernicterus? Bilirubin basically binds with albumin. But if the albumin is decreased, then that will increase the free unconjugated bilirubin which goes and deposits in the brain. Similarly, certain drugs like sulfonamides lead to displacement of the bilirubin because they have a higher affinity for the albumin than the bilirubin. That lead to kernicterus. Any acidosis, increased free fatty acids can lead to the development of the kernicterus. So, how do you treat unconjugated bilirubinemia? We do the phototherapy. We use the blue-green light, 460 to 490 nanometers. How does it help? It will lead to structural isomerization that will make, even though it is unconjugated bilirubin, that structural isomer formed by the phototherapy is still soluble. So that it won't go and it is easy to excrete it. That's conjugate excrete it mamalga. But then structurally, if you isomerize by using the phototherapy also, you can get it excreted. Okay? So this is how phototherapy done. Now what are the complications of phototherapy? Bronze baby syndrome, macular erythema, they all are the issues. Retinal damage can occur, loose stools. Phototherapy in a baby ki continuous loose stools. Fever can develop, so we keep monitoring the temperature. Loose stools is okay, acceptable issue. Then when do you do exchange transfusion? पूरा उनका खून निकाल के मशीन में क्लीन करा के फिर चढ़ाते. Whenever there is any RH isoimmunization and the hemoglobin level in the cord is only less than 10, that means there is already a lot of hemolysis. Bilirubin is more than 5.5 and packed cell volume less than 30 is an indication. In that, single volume exchange ante 80 ml per kg, double volume is 160 ml per kg. Okay. Similarly, when will you do, what is the cutoff value of the total serum bilirubin for you to do phototherapy exchange transfusion? In the preterm and term baby. కొంచెము చూడండి ఇది. Now, caput succedaneum versus cephalohematoma, you need to differentiate. What is caput succedaneum? So basically, it is the edema of the newborn baby scalp. ఇదేంటంటే frank blood cephalohematoma. Right? So, caput succedaneum is present at birth. It is above periosteum, so it crosses suture lines. And in case of cephalohematoma, it is subperiosteal, limited by sutures. Edematous, ecchymotic, boggy scalp is the feature of caput. And caput resolves in 24 hours, no treatment needed. But cephalohematoma appear 2 to 4 days after the birth. It is subperiosteal. And it will take 2 weeks to 3 months. It can even calcify. It is blood. And cephalohematoma, all that blood can release bilirubin and lead to jaundice. That's the reason it required phototherapy. Okay? So this is how typically, doctor, a cephalohematoma which is limited by the suture lines, and a boggy swelling not limited by suture lines is caput succedaneum. Clear? Now, హండ్రెడ్ వరకు కొట్టేసి వెళ్దామా? మిగతా చదవగలగాలి మీరు. కొంచెం చాట్ జీపీటీ పెట్టుకుని ఎక్కడైనా డౌట్స్ వచ్చినాయి అనుకోండి, ఆ ఇమేజెస్ అవి ఇవి కొంచెం చెక్ చేయండి. What is the time?
9:10.
Oh man. My appointments are planned from 10 o'clock. What is the 1 hour 45 minutes?
Yeah.
Okay. We'll persist for another 15 minutes. Now, what is the plan of the fetal circulation? Umbilical venous blood is fully saturated with oxygen. Generally, umbilical vein is oxygenated, umbilical artery is deoxygenated. Reverse. Umbilical vein directly joins the IVC, bypassing the liver through ductus venosus. So umbilical vein to ductus venosus to IVC. Then from where will IVC receive the blood? One is oxygenated blood coming from umbilical vein, right? Lower body blood, because directly IVC carries the lower body blood, and hepatic veins. So IVC drains into right atrium. There the blood gets split. From right atrium, 2/3 will go to right ventricle, but 1/3 will go into foramen ovale. Through foramen ovale into left atrium. So SVC brings the blood from head, neck to upper limbs. So whatever the blood that moved from right atrium into लेफ्ट एट्रियम को जाता और राइट वेंट्रिकल को भी आएगा. राइट वेंट्रिकल को जितना भी आया है वो पल्मोनरी आर्टरी में जाएगा, और pulmonary lungs are not working, no, so no point in pulmonary arteries taking to lungs. Instead, through the ductus arteriosus, it will directly connect with the descending aorta. and it goes down. Descending aorta supplies umbilical arteries, lower limbs and kidneys. Okay? And the left ventricular output, which has gone into ascending aorta, will supply the coronaries, head, upper body. So where is the highest oxygenated blood there? IVC, followed by right atrium. Then whatever shunted through foramen ovale into left atrium, into left ventricle, and the ascending aorta. Well, descending aorta is impurified by the impure blood coming from pulmonary artery through ductus arteriosus. Okay, sir, Mala, I'll walk you through. देखिए डॉक्टर साहब, umbilical vein है ना?
Yeah.
Umbilical vein through ductus venosus will enter into IVC. IVC is bringing the bad blood from the lower limbs, lower part of the body, and good blood came through umbilical vein. Together they enter into right atrium, and right atrium is also receiving the bad blood coming from SVC. In this, 1/3 of the blood will enter into left atrium, and 2/3 will enter into right ventricle. And from right ventricle, it will go into right ventricle, pulmonary artery, and from the pulmonary artery, through ductus arteriosus, it will go and merge with descending aorta.
Yeah.
Descending aorta. And that's the reason descending aorta has got impure blood brought by pulmonary artery. And that gets circulated throughout the body.
Yeah.
Now, whatever the oxygenated blood is pushed into the left atrium will go into left ventricle. And from left ventricle, it will go into ascending aorta. It still is not impure, because it received blood from right atrium's good blood gone into left atrium, into left ventricle, into ascending aorta.
Yeah.
The moment it becomes descending aorta, there's more amount of impurity.
It's the same blood.
Huh?
Same blood, right? So the umbilical vein plus IVC and SVC will mix in right atrium. So,
Will mix in right atrium,
yeah.
and that bad blood is going into pulmonary artery and mixing with the descending aorta, and that is all deoxygenated.
Yeah.
You mean to say
It'll all be the
this
same.
blood gone into left atrium, into left ventricle, into, but if you look at the oxygenation levels,
Yeah. Oxygenation.
oxygenation levels are highest in umbilical vein,
Yes.
then right atrium, then left atrium, then ascending aorta. A descending aorta low, because it got impurified by the blood that came from the pulmonary artery through ductus arteriosus, it is more impure. Atla. Huh?
Yeah.
So this sequence you need to remember. So ductus venosus closes by 7th day after birth. Ductus arteriosus anatomical closure is 10 to 25 days after birth. Ductus arteriosus functional closure is within 15 hours after birth. Similarly, foramen ovale functional closure, the one between right atrium, left atrium,
Yeah.
is by first breath.
Okay.
Anatomical closure around 1 year of age. కొంచెం ఇది రివ్యూ చేయండి.
Yeah.
Part 1 over. ఇట్లుంటారు మా స్టూడెంట్లు. अभी अभी उठ गया है सर. आप सुबह सुबह नौटंकी शुरू करें तो क्या करेंगे? So doctor, hustle until the exam. There is no other option.
Yeah.
Do we have? నో. ఒకటే డ్రీమ్ ఉండాలి, ఎట్లనైనా నా స్కోర్ పెరుగుతుంది. ఎందుకంటే యు ఆర్ రీడింగ్ మోస్ట్ టెస్టెడ్ కాంటెంట్. సో దెర్ ఈస్ నథింగ్ దట్ యూ కాంట్ అండర్స్టాండ్ ఇన్ దిస్. Anything you put in ChatGPT, explain me, it will explain. You need to have patience, right? No need of any national teacher, some super duper guy to come and. Only thing is, a couple of hours if I spend time, you will get that conviction. By chalo, 50 साल का मुरली भरद्वाज और 25 साल का मैं, हम दोनों का जुगलबंदी में थोड़ा कुछ इंटरेस्ट जनरेट हो जाता. What is Holt-Oram syndrome? Ostium secundum type of ASD with first degree heart block. మీకు గుర్తుందా? ఫస్ట్ డిగ్రీ, సెకండ్ డిగ్రీ, థర్డ్ డిగ్రీ. సెకండ్ డిగ్రీలో మళ్ళీ మోబిట్స్ టైప్ 1, టైప్ 2. సో ఫస్ట్ డిగ్రీ అంటే ఓన్లీ పిఆర్ ప్రొలాంగేషన్. సో ఆస్టియం సెకండమ్ ASD ప్లస్ ఫస్ట్ డిగ్రీ. Maternal rubella will lead to PDA most common, even pulmonary artery stenosis. Turner syndrome में there will be a bicuspid aortic valve, most common, and coarctation of aorta is second most. Diabetic mother में baby born to. Transposition of great vessels, VSD, coarctation of aorta, and primary pulmonary hypertension. They're all common in the infant born to the diabetic mother. Williams syndrome में Elfin's phases, mental retardation, hyperglycemia. What is the meaning of Elfin's phases? Long upper lip length, philtrum, wide mouth, then small and widely spaced teeth, puffiness around the eyes. Did you ever Elfin phases, which is seen in Williams syndrome. They will also have mental retardation, hypercalcemia. Then Down syndrome, what do you get? Endocardial cushion defect, that is ventricular septal defect. And which type of ASD is most common in Down? Ostium primum type of ASD is most common. Then there is an entity called 22q11 syndrome. In this, you get truncus arteriosus and tetralogy of Fallot. Then what is Noonan? Noonan is the male counterpart of Turner. In this, there is a hypertrophic obstructive cardiomyopathy and dysplastic pulmonary valve. And if the mother drinks alcohol, baby will get VSD, ASD. Marfan syndrome, what do you get? Mitral valve prolapse, aortic root dilatation. Then if there is a SLE in the mother, anti-Rho antibodies will lead to complete heart block. If the mother is using lithium for maniac depression, then the baby will get Epstein anomaly. What is Epstein anomaly? Tricuspid valve, instead of being placed in the between right atrium, right ventricle, it moves a little lower towards the ventricle. So that is called atrialization of the ventricle. Ventricle ka अड्डे को वो कब्जा कर लेता एट्रिया because of the lower placement of the tricuspid valve. So this Epstein's anomaly is very common when the mother is using the lithium. Next comes Dr. Pulmonary plethora and pulmonary oligemia. What is plethora? Increased vascularity of the lung is called plethora. This is called, all this vascularity is increased. Then what is pulmonary oligemia? Typically pulmonary vessels became scanty. Why do you develop pulmonary oligemia in tetralogy of Fallot? In tetralogy of Fallot, there's a pulmonary stenosis that will prevent the right ventricle blood entering into pulmonary artery. That's the reason there is a pulmonary oligemia. Whereas in the case of the ASD, VSD, PDA, what's happening? The left heart blood is, atrial blood is entering into right atrium. Right atrium is receiving regular blood flow and also left atrial blood. Together will increase into the lungs. From right atrium, right ventricle into lungs. That's the reason pulmonary plethora is the feature of ASD, VSD, PDA, pulmonary oligemia is the feature of conditions like TOF. Okay, doc?
Yeah.
So what are the conditions where you see left axis and right axis? Ostium primum ASD, VSD, PDA, endocardial cushion defects, we see left axis. ASD, ostium secundum, tetralogy of Fallot, Eisenmenger. Eisenmenger means whenever pulmonary hypertension develops, the left to right shunt become converted into right to left shunt with cyanosis. Any right to left shunts will lead to cyanosis. Left to right shunts are good mixing with bad. So they are acyanotic. So coarctation of aorta in infants. Then total anomalous pulmonary venous circulation. What is the meaning of that? The pulmonary vein, instead of draining into the left atrium, is draining into the right atrium. Right atrium is also receiving the
No, the
SVC, IVC.
Yeah.
And that is called anomalous pulmonary venous circulation. Now some most commons. Most common congenital heart disease overall, VSD. Most common cyanotic congenital heart disease overall, TOF. Most common cyanotic heart disease in neonates, transposition of great arteries. Most common acyanotic heart disease, VSD. Most common obstructive congenital heart disease, aortic stenosis. Like that, every category has got a category award. Goes to. Huh? So I leave this literature for you, doctor. And in coarctation of aorta, what do you get? Three sign. Because the coarctation means narrowing. Because the narrow, above and below will dilate. So 3 sign, notching. Okay. So with this, we'll call it a day, doctor. And thanks for persisting with me for 2 hours. So MS is saying you're a great teacher, sir. Is it, Viraj?
Sir,
Oh, thank you. The only incentive and compliment is when students are able to get inspiration to read, doctor. No teacher can teach you. Remember, teacher can add a little bit of inspiration saying that I will also wake up at 5, you also wake up at 5, right? And give you some good habits to persist on reading, which should reflect in the score. Adi, simple. So that's the reason after the class is over, take a power nap or do a gym exercise. Then you sit and finish the remaining part of the PDF and then take a mock test, check your score, evaluate your mistakes. Slowly, रोज एक कदम बढ़ते जाएंगे और 20 दिन में you will reach the safe zone. Simple. Thank you.